Hi everyone. This is the Building Brain Awareness Talk series where we talk about brain injury related stuff, and Dr. Ethan Danielli is presenting today. This is a really interesting discussion where I look at the brain injury symptoms or post-concussion symptoms are something that people don't always understand, or in my experience and many others believe they don't understand what you're dealing with, so they don't believe it because you can't see it, but it is injury to the brain. So his data in his research showing the injury to specific brain regions gives an actual injured part to then connect with the symptoms, and the brain is extremely vast and complex. Just having this data is, I think, a really good foundation for helping people understand and think about the nature of brain injury. Ethan, why don't you take it away and introduce yourself further if you'd like, and thank you very much for doing this presentation.
Oh, absolutely. Thank you for having me. Yeah, I'm open to kind of running through my presentation and having questions after, or interrupt me as we go. That's okay too. Um, so yeah, today basically I just want to share some of the things I've learned over the years doing research in the concussion field and using MRI to look at the brain, which is it's a challenging part of the body to learn about when you can't actually see it or feel it. So that's why we've found that MRI is a really powerful tool to let us see what's actually going on inside. Just to give you a bit about myself, I'm a lifelong soccer player. Grew up in Guelph, Ontario, and in Canada, where I went to university as well. But as all Canadians, pretty much, you grow up playing hockey as well. So I have lots of friends and family who have experienced different types of brain injuries over the years. Experienced some myself from playing sports, and I appreciated when Dan reached out to me, and it's partially what got me inspired into this field of research in the first place of coming from it from a personal experience and understanding the huge impact that a brain injury can have on somebody. A bit more about me in terms of where I'm coming from with this talk is I studied human kinetics at the University of Guelph as an undergrad, and then went to McMaster University to do my PhD in biomedical engineering, where the focus mostly was on the work that I'm talking about today, looking at concussions and um, trying to use MRI to look inside and see what's going on in terms of what happened after that injury and connecting that with the symptoms that people were sharing. I then took a postdoc position in Toronto and have now come back to Hamilton, back to McMaster for another postdoc position where I'm in kinesiology at McMaster, doing some ketone and brain health research. Also, just to disclose, not that this has influenced the presentation at all, but as part of this research the last couple of years, I've been part of a small startup company in Hamilton. Part of it's been based on some of the research I've done over the years, but what it does is called concussion MRI analytics, and what it does is perform personalized assessments of head injuries using the MRI and using a lot of the things I'll talk about today. But um, I've just been working as a kind of a research coordinator with the company. So the kind of context for today's talk is about a paper that I published a few years ago with my supervisor, Mike Noseworthy, and a couple of other of our colleagues. And it was a review paper that Dan saw published in Frontiers in Neurology, where it was a review paper on brain regions that were and what their normal function was compared to the post-concussion symptoms that they could be associated with. So that's that's where the focus of today's talk will be. I'll kind of linking it back and forth with that paper. Through the presentation today, I'll talk about post-concussion symptom domains, kind of categories of symptoms someone might experience, talking about different brain regions themselves, trying to kind of tease apart the brain, which is very complex and highly organized, and then talking about MRI as a capable technology to look at those injuries and how it could be used for kind of a new form of concussion assessment and management. Today, the kind of key message that I want to hammer at is that MRI can help concussion assessment in terms of moving away from kind of subjective measures of assessment and maybe somebody not believing your symptoms, but maybe being able to provide an actual objective measurement to what's going on with your brain. So I know this is a group that knows a lot about concussions and traumatic brain injury, so I don't want to go too deep into the behind the scenes of concussions because we know the prevalence and vast array of things that can come about from them. But today I'll be mostly focusing on concussions and just the high degree of variability between people and the symptoms that they might experience. And from what we know, most people would recover within the first like 1 to 3 weeks, but there's also a high percentage of people, somewhere between 18 to 30% of people that have those symptoms not go away after a concussion and could be dealing with those for years or the rest of their life. We also know that there's sex differences in and gender differences in terms of not only the injury severity and presentation, but also things like reporting their concussion and how somebody might um, try to play through an injury versus actually report it and seek medical attention. And through all of that, a major ongoing challenge is trying to define what persistent post-concussion symptoms are, teasing that apart from other things like anxiety, depression, or anything else that somebody might be experiencing, and help kind of form a more consistent basis of research and clinical practice to help standardize treatment for people. So, kind of going into this types of symptoms, there's again, as you know, there's so many different symptoms that somebody could experience. Somebody might experience one symptom or all of them. Some might come or go, um, and may improve over time. Now, in general, there's kind of four categories of symptoms, broken down as somatic, cognitive, emotional, or sleep. Somatic would be symptoms that would be in terms of sensation, motion, or things like dizziness or visual problems. Light sensitivity, anything to do with sensation. Cognitive, maybe more self-explanatory, feeling slow or foggy, having memory issues, changes with your speech, um, or comprehension. Then you have emotional. So this is a really common one, and often gets mixed up in terms of concussion assessment, is anxiety or sadness around the injury, but is also a symptom of getting a traumatic brain injury. And then changes to sleep. So either sleeping too much, not able to sleep, having trouble falling asleep, or just having general fatigue throughout your daily living. And one of the challenges with the current concussion assessment is most of it is still based on subjective symptom tracking of trying to figure out how you're not only assessed, but if you're getting better or if a treatment is working. And when imaging is brought into play, things like clinical MRI or CT scans are often used, but they're not able to identify concussion related or traumatic brain injury related injuries unless they're quite severe, like a brain bleed, or very obvious structural damage. But that often is not the case for concussions. And there's still also a high variability in terms of clinicians, in terms of how they would assess you, how they would diagnose you, or prescribe treatment. And I give this image as well because the image on the left is actually my brain. The image on the right is one of our research participants. And we just look at them. There's no real difference. But the person on the right has had some very serious concussions over the years. But you'd have no idea just by looking at it. Those concussion injuries can be really small, microscopic, and visible injuries are not obvious. Where concussions may involve damage to axons, which is the white matter, functional changes to the gray matter, to the neurons actually creating all those signals that your brain's able to send and capture, which is not possible without specialized a functional MRI scan. Disruptions to the vasculature or blood flow around your brain, or metabolic changes with energy usage and supply, making sure your brain has the fuel it needs to perform its normal everyday functions. And one of the challenges with clinical MRI is that they're just not designed for that, and we don't have the techniques available for easy implementation into routine practice. So a lot of this ends up staying within the research world. For those of you that don't know what an MRI is, I also wanted to put this image in the presentation. This is the scanner we actually use at our hospital in Hamilton. And um, hopefully you can see my cursor as well. There's the bed or the table that somebody would lay in. There's the big donut, which would be the MRI itself. And you'd put your head for somebody who's got a brain injury, they would be getting a head scan. So they'd be putting their head in that smaller, it's called a head coil, at the end of the table. And once you're ready to get scanned, this whole table would slide inside the donut in the machine, and that's where we would take the pictures. It's quite loud, but you can put headphones in and either just have noise canceling headphones or listen to music. But um, I've been scanned many, many, many times, and at this point, I fall asleep in the scanner. I find it pretty relaxing. In terms of MRI compared to other technologies, it's a really cool technology in terms of not only its safe, non-invasive nature, but it also can provide a whole bunch of different types of information using the same equipment. So we can look at structural changes, functional changes, blood flow changes, metabolic changes, looking at bleeds or tearing, all with the same technique, all with that same equipment that I showed you in the previous image, where that's not capable or possible with other types of medical imaging. Um, so MRI really has a leg up on other technologies and can provide the information that we would actually be expecting to see changes because of a concussion or traumatic brain injury. Um, and just to also provide some information about the brain, some kind of basic brain anatomy would be looking at the brain from a kind of a side angle. This is hopefully a view that most people would recognize. Um, on the left side would be the front of the brain, kind of where somebody's forehead would be. The back of the brain would be over on the yellow side. Um, and so the orange section would be the frontal lobe. The green section is called the temporal lobe. The frontal lobe is more responsible for decision making and kind of executive function, and whereas the temporal lobe is involved in other things bilaterally. There's left and right differences. The left side is highly involved in language production, and it's also kind of right beside your ear, so there's lots of auditory information provided as well. The parietal lobe up on the top part of the brain is highly involved in sensation and motor control, and the occipital lobe highly involved in visual processing. You also have this little part of the brain at the back and at the bottom, often forgotten in lots of fields, but it's the cerebellum, sometimes known as the little brain, which I'll talk about that a lot more later, but it's involved in many, many facets of cognition and used to be used to be thought to only have to do with motion or movement, but it's much more involved than everybody thought. Going back to the MRI, I wanted to provide some kind of further diving deeper into the parts of the brain in terms of the brain regions that I'll be talking about. So this would be an anatomical picture of somebody's brain, and from several different perspectives. Their main tissue types within the brain are gray matter and white matter. Gray matter would be parts of the brain that are where the neurons are, where you're actually producing thoughts and initiating movements or things like that. The white matter is basically the highways connecting all the parts of the gray matter. It's the connections sending the signals between different parts of your brain. So you can hopefully kind of see that distinction on this picture on the left, where the whiter, brighter part is in the kind of center of the brain, the darker, grayer part around the outside of the brain, and then some deeper parts in the middle would be the gray matter. I've gone one step further just to try and highlight the gray matter part in red there for you, and the white matter in yellow. We can also learn a lot more, partially what we're talking about today, is diving deeper and breaking up that gray matter into really small specific parts of the brain that are all responsible for different functions and different actions. So this is an example of a brain atlas that breaks down all of those gray matter regions as much as pretty thorough coverage of the entire brain. So each of those different colors would be a different part of the brain responsible for a different action, function, whatever you want to call it. And the white matter can also be broken down into different tracks or connection points, which are groups of white matter fibers that are, again, acting as kind of like a highway between the different gray matter cities. So bringing it back to the paper that Dan originally reached out to me about, we looked at 15 different gray matter regions, 10 different white matter regions, and looking at the cerebellum in 10 different regions as well, breaking it up into smaller parts to try and look at what's going on in these different parts of the brain in terms of how they should be functioning, how we would expect them to be functioning, and then if somebody was to get a traumatic brain injury, what post-concussion symptoms could be associated with that individual part of the brain. The idea and the context was if somebody is just presenting with symptoms and they're not getting better because the treatment isn't working, wouldn't it be great if we could understand what's going on inside the brain and maybe explain that to a clinician who might be able to tailor a treatment a different way or something like that, as well as provide kind of evidence, not only to yourself, but to your clinicians, family, whoever, that no, there is a part of your brain that is injured, abnormal, or on the way to recovery. So this is a visualization of all those different brain regions. A list on the previous slide isn't very helpful, so this is hopefully a little bit clearer in terms of the different parts of the brain we are covering. In that left column, it was all gray matter regions, so those are the parts where there's the neurons and the actual parts of the brain functioning. The middle is the white matter regions, which are the connections. And on the right is the cerebellum, which is that little brain at the back, which again, I'll explain all of its different functions shortly. In the table, we outlined, or in the paper, sorry, we had multiple tables to help summarize all of the functions and symptoms that would be associated with each brain region. So I just provided a bit of a highlight there, but from what we found, I'm going to kind of go through by the domains of the different regions or of the different types of symptoms you might expect and kind of give you some of those highlights of which brain regions were most expected in terms of the symptoms. So looking at the somatic domain, and just as a reminder, somatic domain would be sensation, motion, and aspects of visual sensitivity. And part of the brain, the insula, is highly connected in terms of integrating sensation and kind of your brain's perception of the world. And so on its normal functioning, it's quite involved in understanding the brain's sensations from different aspects of different parts of the brain, sending signals to it, and then it's able to interpret it. And so some of the symptoms in terms of somatic that you might experience could be headache, dizziness, or nausea. The lateral geniculate nucleus, a smaller brain region. It's mostly involved in the visual cortex in interpreting visual information. So that would be symptoms related to light sensitivity or visual changes. The primary somatosensory cortex, again, involved mostly in perception of sensation and how the body is able to interact with the world. So if you had that part of your brain injured, you would likely have altered sensation or maybe hypersensitivity to different sensations. And the visual cortex, of course, which involved in visual processing of all sorts. So you may experience light sensitivity, disturbances, blurred vision. You could experience things like nausea or dizziness because of those visual changes as well. Through these next couple of slides, I included a couple brain regions that weren't included in the review paper, but I thought would also be relevant and helpful. And I just have an asterisk beside them because they weren't in the paper specifically, but wanted to talk about them today. The thalamus It's a deeper brain structure. And it's again a critical hub for sensory information. And it would be similar to the insula where you're maybe having lots of sensory hypersensitivity or dizziness related to damage to the thalamus. Looking at the cognitive domain, so basically anything to do with cognitive function. Um, the amygdala is a really important region for that, which is highly involved in emotional processing, but also involved in memory because its close connection to the hippocampus. Symptoms you might experience would be feeling slow or foggy, having trouble remembering or learning. Broca's area, which is in the left side of the temporal lobe, it's essential to language production. And it would be, if it was injured, you would experience maybe feeling slow or foggy, but likely some speech or language related challenges. The hippocampus is one of the most research aspects of the brain. It's involved with every aspect of memory, but also has some connections to executive function as well because your brain relies on memory and working memory so heavily. With that, you would definitely experience challenges with your memory or feeling foggy, and maybe having challenges learning something new. The mammillary bodies are quite small little brain regions, but they're quite connected to the hippocampus and the memory circuit. And so you might have experienced difficulties remembering. And then two more brain regions that weren't in the paper, but the cingulate cortex and the prefrontal cortex. The cingulate cortex is highly involved in attention and memory, and the prefrontal cortex, which would be in the frontal lobe, kind of at the front of your brain, highly involved in executive functioning, memory, and impulse control. So you might have trouble concentrating or having decision fatigue or unable to make decisions if either of those regions were affected.
The symptoms here is not what people describe, but what you conclude based on the functional rationale? Or how does,
Um,
yeah,
yeah, so we from the review that we did, we some of the sim we are connecting some of the symptoms based on what the normal function would be, but we also were looking for papers that were actually finding evidence in people with brain injuries or maybe had something else like maybe a brain tumor that affected that part of the brain, and then they lost a specific function, or would experience a symptom based on a surgery or tumor. So um, the symptoms that we're reporting would be common symptoms that would be associated with concussion. Yeah.
yeah. A lot of the people here are people who have brain injuries that describe these kinds of things. I've recorded discussions with them and the memory differences,
Hmm.
there's a certain wording that gets teased out when it's a lived experience versus a review. But yeah,
Hmm.
just for clarity. Another thing, so with the data set that you had to find people that had only injury to those regions. Is that true? Or was there
Um,
most brain injuries? I imagine most brain injuries will have a vast coverage of parts of the brain hurt or injured, or you know, it's not always region specific.
yeah, exactly. So the review we did was only a literature review, so we didn't actually have participants for this specific project.
Right.
Um, so it was based on um, learning about what other studies had shown. In terms of what we would expect, you're absolutely right, and that's partially why this paper we thought was quite important, was um, when somebody gets a brain injury, it never looks the same across multiple people, even if it's the same kind of like event. Somebody might have a small part of their brain affected, somebody might have quite a large part of their brain affected, and it likely wouldn't be associated with only one part of the brain. It's
Right.
likely multiple. And as you can see from my summaries here, that there's a lot of overlap between the regions and a lot of overlap between the function, like the normal function as well, like the expected function. So um, that's one of the beauties of the brain is the complexity and ability for adaptability if there is an injury or changes over time. But it is hard to tease apart what's going on sometimes when there are multiple areas affected that are doing similar things.
Right. There's a question in the chat about the before and after.
Oh,
Is
sure.
there's not a lot of imaging before the brain injury because there's no reason. So how do you conclude that there is injury? Or what kind of information do you use to ascertain that?
So there's kind of different schools of thought with this as well. The most common in terms of research would be a normative or healthy control group, similar across almost all fields of research, but to have some reference of what that brain region would be doing without a brain injury. And that's really commonly done in concussion research as well. But what we found was that it's really hard to find meaningful results and inferences when so many people have unique injuries and different symptoms or different events that cause their injury. So something that we've been doing that was a big part of my PhD was using kind of a personalized assessment.
Hmm.
So you get a large number of, and I say healthy or normative data sets, but really it's such a broad range of people, and there's no real normal or healthy. But I guess I use that in the context of it wasn't people with currently experiencing a brain injury or some specific cognitive event. But basically, if you had a large number of those healthy data set, you could then compare that one concussion patient to what would be expected across all of those little brain regions let me go back to the slide up here. Um, Oops, went too far. This, for example, we can know what in, this pink band here through the middle of the brain, we could know what values and function would be expected in that across a whole bunch of normative people, healthy samples, and then compare the function of that same part of the brain post-concussion and see if there was an injury, see if it's functioning differently. Because to us, it really wasn't making sense trying to compare a group of people when their injuries were so unique.
Yeah, of course. I mean, that's part of the problems with brain injury. I think to
Mhm.
find some standardization is very important. And also, most brain injury people I meet, the outside world has no clue what they're dealing with and doesn't believe them. So again, this is injury to the brain. So this is a rational way to show it. Anyway, please continue. Does anyone else have any questions? Latest question is in the chat. When you say different symptoms, do you account for the variation in the perception and
Mhm.
communication of the symptom? I notice others have similar problems, but they may describe it differently or focus on only a few of the symptoms when I see many more that are not describing. So yeah,
That's that's a really good question, and that's where that was kind of part of the emphasis of using imaging, like more advanced imaging techniques, like I'm talking about today, because simply relying on the symptoms, a 0 to 10 scale, for example, people's 7 out of 10 is hugely different between people. Um, Somebody might be experiencing the worst pain of their life, and they still wouldn't say that they're 10 out of 10 pain. Um, so it's really hard to interpret how serious symptoms are on a person-to-person basis. So that's where we in our research we try and collect that information through self-reporting, but we always want to have that across multiple questionnaires or assessments, and then try and align that with the imaging that we do because um, we're hoping that we can provide that evidence that the brain is affected and might be presenting in those symptoms that the person is showing and feeling. So it's a really good question. It's a huge challenge in the field for sure.
yeah, I think every brain injury person I've spoken to describes a list of problems, and the internal experience of that is very strange because sometimes the problems accumulate. Sometimes one is manifesting more strongly than others and they change in unique ways. Have you gotten into DTI imaging at all or
Yeah. So I can quickly just talk about that as well because the gray matter regions that were kind of at the top of the screen here and I've been talking about so far, the kind of main things that you'd be looking at would be using a functional MRI or an fMRI. A lot of people have heard of that. Essentially, you're looking at how the brain's functioning, um, and in terms of their blood flow and kind of metabolism as a kind of a surrogate for neural activity. You can do that in different forms in terms of looking at a resting state fMRI, which is just having somebody lie there and not think or do anything in particular, just to see kind of baseline brain function, which is a lot of where we do our work in that kind of realm. Another method of fMRI would be to do a task-based scan. So have somebody um, repetitively do a specific task and see might be a math problem. You expect a certain part of the brain to be active to do math. So you would be assessing to see how that part of the brain is functioning or the rest of the brain is functioning relative to trying to do math. What Dan mentioned is DTI, which is diffusion tensor imaging, which is really measuring the flow of water through the brain. It's really, really informative for looking at white matter regions, which I've outlined on the bottom there, because white matter is essentially a whole lot of channels surrounded with insulation. And that insulation is myelin, which is almost all water. So by using DTI, we can measure the um, integrity and shape of that myelin and essentially the white matter to see if it's healthy or been stretched or torn, if there's inflammation. And that can be a highly informative way to see if those highways or connection points, which is the white matter, is damaged. So that's a great question, Dan. I think I was around here for kind of going into the emotional domain. We were one of the first groups to try and do this in terms of a review. So it wasn't perfect and it wasn't fully comprehensive across all parts of the brain, but we really wanted to try and provide some context and basis for connecting brain regions with the symptoms that somebody might be experiencing. So in terms of emotion, these three are highly involved in different aspects. The amygdala is one of your most important emotional processing centers. People often call it the fight or flight part of the brain. With changes there, you could experience any kind of emotional changes, like irritability, sadness, anxiety, just generally more emotional. The hippocampus, although its primary focus is memory, it's right beside the amygdala. They're highly connected, so there could be some play off of each other there. And the insula, like I mentioned in the somatic domain, it's highly integrated with body sensation and emotion and kind of connecting all aspects of brain function and activity. So there certainly could be involvement in different post-concussion symptoms there as well. I also wanted to highlight these two brain regions again. They're large and highly connected in terms of integrating and communicating different cognitive functions and emotions. So the cingulate cortex and the prefrontal cortex also could certainly play a role in causing some to be present. And then the last one is to talk about the sleep domain. The amygdala comes up again. It is emotion has a quite a strong connection to sleep. And if you're really heightened, it might cause you trouble falling asleep or having a loss of sleep. The insula has a strong influence over autonomic regulation. So that would potentially cause you changes to sleeping too much or not enough. And then something we didn't include in the paper, but certainly relevant would be the brainstem and the thalamus. The brainstem and the thalamus are both deeper brain structures involved in more basal functions. So the brainstem would be involved in consciousness and wakefulness, and controlling some of your autonomic system. So you could experience fatigue or too much sleep with that. The thalamus um, is highly involved in sleep regulation and sensory integration. So, similar to all these other brain regions, could present with that changes to sleep. Moving on to white matter, I just wanted to highlight three different regions. The acoustic radiation is your primary connection of white matter from your ear to where auditory processing happens in your temporal lobe. And so if you had damage to this white matter structure, you would likely experience changes to your maybe sensitivity to noise. That may also play in with changes to language and interpretation of what you're hearing. The cingulum, which is essentially the white matter tract that communicates for the cingulate cortex, um, is right through the center of the brain and highly connected in terms of communicating across the left and right part of the brain and sending connection from the cingulate cortex to many aspects of the brain. As you can see, it wraps around quite extensively. So it could be involved in many types of symptoms across the different domains if it was injured, as well as the superior longitudinal fasciculus was one that came up quite extensively. It's been researched quite a bit. It's a larger white matter tract, and it is more closely related to the parietal lobe and the motor cortex. So you might be experiencing more motor control problems or feeling some kind of fogginess. But it has connections down to the parietal lobe as well. So you may have language changes as well. And from those gray and white matter regions, I wanted to highlight the insula from the gray matter and the cingulum from the white matter as kind of um, symptom hubs in terms of what we found in our research. And partially because these regions are quite interconnected um, with other parts of the brain, they end up crossing many of those symptom domains and could have somebody experience a multitude of symptoms if there was damage to that specific part. But I wanted to then move into the cerebellum because the cerebellum often gets forgotten. Historically, it really was only known to be part of helping with balance and motor control and motion. But in the recent years, it's been researched quite a bit more, and it's now recognized to contribute to many, many aspects of cognition. So, would be noteworthy would be like attention, executive function, emotion, memory, social cognition, vestibular processing. Vestibular would be like balance and motion. So, um, one of those regions that I wanted to highlight was the Crus 1, which you can see in blue there in the image. It's a larger part of the cerebellum, but it has roles in most of those functions. So if there was an injury, to the back of the brain and the Crus one was affected, you could experience a number of different symptoms related to balance or dizziness, related to emotion or memory. You could have some irritability or emotionalness, or things like with executive function or attention, you feeling foggy or difficulty concentrating. So this is definitely a newer frontier in terms of concussion research and brain research in general, where the cerebellum has often been forgotten and assumed to only be responsible for motor in the past. With all of that said, there's um, there's different kind of treatment options for different types of symptom presentations. Definitely not a one size fits all and might not work for each person, but this group from Buffalo has done an extensive amount of research in concussion and in the treatment of concussions, and they did a really nice review paper a number of years ago, um, and and then included participants to try and identify different subtypes of persistent symptoms. And we're able to kind of distinguish between the physiological participants, so people experiencing metabolic changes where any amount of exercise or activity might make them nauseous or dizzy and unable to continue on. Then there was vestibulo-ocular, which was really balance and eye related, or the cervicogenic, which was really neck and kind of head positioning related. I think there's important to also note cognitive and emotional is certainly could overlap with any of those and certainly could influence your presentation and kind of recovery trajectory. An example that I wanted to highlight here would be in terms of using the technology of MRI and kind of what I've been talking about was if somebody, for example, came in and they were talking about light sensitivity and headaches and visual changes, but weren't able to kind of understand what was going on. If we were to do a brain scan of them, we would um, expect, and obviously there could be other parts of the brain affected, but we would expect changes to the visual cortex, which is highly involved in all aspects of visual processing, the optic radiations, which help bring visual information, optic information from the eye to the visual cortex, and the lateral geniculate body, which is, I mentioned earlier, is a hub for visual integration again, from the eye to the visual cortex. So the goal that we were going with wasn't just to identify injury, but to kind of provide this basis of understanding behind the symptoms and try and encourage people to fix the source and not just the symptom. So certainly there's lots of room for future opportunities, and um, I think the research field is moving towards this mindset of more personalized assessments and trying to encourage um, these to be implemented into clinical practice because there's certainly a need um, to give people answers and to hopefully help guide the treatment trajectory a little bit more specific to them. So just finish off with some take-home points of the vast array of changes that could be related to your brain from a brain injury, um, unique to each person and um, highly unpredictable and challenging when it comes to um, these symptoms evolving or not going away with different treatments. The many different structures that contribute to the brain and could influence symptom presentation, and the different types of MRI that could be used to go beyond conventional imaging. And hopefully this gave you some idea in terms of the symptom to brain connection in terms of a personalized concussion assessment. So with that, I just wanted to provide a couple more papers in terms of the research our group has done. This is all work led by Dr. Mike Noseworthy from McMaster University, and some of the research that his group, myself included, have done over the years. And just thank you very much for having me talk today.
Thank you, Ethan. Yeah, that's really interesting, and I have a ton of questions. So before I ask a few, anyone else here that has any questions or thoughts? Mark just put his brain imaging scan in the chat.
Okay.
You'll notice an extreme change in the right, is the right frontal lobe region, but Mark's been living with that for a long time. Are there any questions?
I have a question, if I may, just
Yeah,
for
please.
clarification about that there's many types of imaging, way more than I ever knew, and that's part of what I'm learning today. Is there any value to standard images that came up with nothing because the people weren't really trained to notice things? Is it possible to look at these after the fact and combine them with symptoms and learn?
That's a really good question. The clinical imaging is really helpful to rule out or identify more serious, like immediate dangers, like bleeding or something that might require surgery. But if those aren't present, you wouldn't be able to, they're not sensitive enough to do what we would normally do in our lab, which is looking at the function of different parts of the brain.
And so when
Um,
you say look at the function image wise, what does that mean? I don't even know.
no, that's okay. So um, we what functional MRIs or an fMRI, they're not commonly put into like routine clinical head scans, not only because the clinicians are maybe not trained to look at them, but they also can require much more extensive analysis after the picture's been taken, like after the scan, before the data is useful. The changes that if you just looked at the fMRI right off the scanner, it would look like a fuzzy mess. It wouldn't look much like a brain. But when you can add some software to that and actually analyze it, that's when we're able to look at how the brain is functioning over time, like over the length of an fMRI scan, which could be 4 minutes or 6 minutes or 8 minutes. Um, and we're able to understand um, the neural activity of the brain. So some of that uh, likely wouldn't be detectable from a clinical scan.
So if I understand you correctly, the clinical scan, it's not just a matter of the people looking at it aren't trained to see what might be there, but you're saying it might not actually be there to be seen by someone
Hmm.
like you, even with way more training.
Exactly. Yeah. Yeah. It's
And
the same machine can take all these different scans or pictures, if you will. Um, but you have to
but you
do the
have to,
right scan.
yeah, you have to tell it to do something different. Um,
Exactly. Yeah.
The only other thing that I've experienced directly, and I don't know if this is what you're talking about or not, but I had a standard MRI and then an add-on, which was really they took the MRI and they did all these calculations and said very different things. And then all my doctors were like, Whew, I have no idea what that is. So it wasn't really useful enough, you know.
Hmm. Yeah, so that's been a challenge of ours as well. It's a real passion of ours is to try and not let this be created just for research, to actually try and bring it to like clinicians and the public, because it is important to, develop new technologies, but if somebody isn't able to interpret it, it's not very useful, is it? So we try and explain, that's why we try and explain what symptoms might be present if a part of the brain is affected, but also put some context behind it in terms of what we would expect from a non-concussed brain versus a concussed brain. So trying to compare those to show that there's like not only identifying an abnormality or an injury, but trying to give like a severity rating as well.
Hmm. Wow. I kind of want to just bring my brain up and take a look at it. But
Yeah,
yeah, thank you for this presentation. It's
thanks for your
great, and a
questions.
lot of it was over my head, I'm sorry to say.
Oh, thanks for your questions.
I know I've known Nancy for a long time, and she has been trying to understand the brain to understand brain injury and her
I have a,
experiences.
I
Yeah,
have a question.
question. Yeah.
So are you saying, Dr. Danelli, that the regular clinicians, they actually have the correct type of machine? Because I thought the machine was just too basic. Do they have the correct type of machine to do these more in-depth studies, or do they not actually have that correct machine to do it? Um, or do they have the correct machine, but they don't have the training or the ability to do it because of the limitations by insurance, time, all of that, money, all of that? Does that make sense?
Yeah, no, that's a great question. It's a bit of a mix of all of those things, to be
Okay.
honest. Certainly the training and analysis afterwards is a barrier of having to it would be great, and the goal eventually would be that you would get your scan or have the person have a scan, and then you'd have an a value or an output. right away, as if you went to a blood pressure cuff and you could know right away if you had high blood pressure or not. But in terms of the scanners themselves, I don't want to make too much of a generalization, but
Sure.
often if clinicians aren't going to use a specific kind of more advanced scan, um, then they wouldn't pay for the license, like the hospital or something wouldn't pay for the license to do the scan, even if the machine technically could be capable of it. I don't want to be too
But just,
general, but
yeah,
it
yeah, just
certainly
curious.
might be possible that an fMRI or a diffusion scan aren't incredibly um, technical in terms of the actually being able to acquire the information, but um, it might not make sense for a clinic or a hospital to administer those if or pay for a license to do it if no one is using it.
Okay, so then question is, do you foresee this being in clinicians in 10 to 20 years, or is this going to just be a specialized thing that's going to be kind of an out-of-pocket thing like Amen Clinics or something? And I'm not even sure if Amen Clinics does this type of thing, but is this going to be always a separate thing, or do you think it would be put into a clinician situation sometime in the next decade or two? Does that
Um,
make sense?
yeah,
Okay.
I really hope it hits more clinical. I think the more that research can push to create a tool that actually gives an interpretable value right away, the easier it is for a
Right,
clinician to say, I don't need to learn a whole new PhD worth of information just to provide help to my patient. So as research
right.
gets better, I'm really hoping because the more people we talk to, more papers are coming out, different conferences, people are seeing the need and seeing a way through to create the analysis that's required, this kind of personalized approach. It's not one emphasis or of the other, like it's not clinicians necessarily resisting because maybe the research isn't quite there yet. But um, our personal goal is definitely to not let this kind of die in the research world.
Thank you. I just want to personally say I appreciate you and thank you for what you're doing because it's really frustrating when you have a brain injury that happens once every 9 seconds, but you have a bunch of clinicians that it might as well be a rare disease. So thank you for continuing your research and continuing to push this. We appreciate it.
Oh, thank you very much.
In my experience and observation of others, the experiences that are internal somehow keep going unnoticed or unrecognized, or the importance of that. It's when it's your brain, that's the thing you have to deal with all the time, and then having it completely discounted is horrible. So I see what you're doing as definitely progressing towards a need that is very much there, and I'm
Mhm.
surprised by how much it isn't talked about. One thing that is important to note is what your data shows and what you're able to show. I look at it as still only scratching the surface in various ways. For example, the network connectivity of brain regions. Like you can have some region get, like someone can have an experience without having that brain region injured. Memory,
Mhm.
for example, with hippocampal injury, you can have a lot of injury to other parts that still have memory problems. But so it's important for the clinicians to be able to interpret that just because the scan doesn't show that injury. I remember talking to a guy about his face looks different and he can't deal with his face, and his wife, her face looks like a witch. And I was talking to some clinician, and he's like, "Well, does he have documented injury to the fusiform gyrus?" I'm like, "I have no idea, but I know that that's his experience." And the clinician just kind of dismissed it. But this person is living in a weird misery as his face and people he knows, he doesn't recognize them. And that's a clear internal experience that he's dealing with every day. I think it led to some serious psychological problems, but because of that injury, so it's just one example. But yeah, these are the problems that brain injury people are dealing with internally all the time. One question with the loss of self. Oh, Moz,
You can go ahead and ask your question first.
I was gonna say with the loss of self with brain injury, I've thought about it for a long time. Is all these internal changes happen to a person, and then you lose yourself because you have lost who you were. But in other cases, people injure like the putamen or parts of the brain that really are thought to create the self. Do you have any data on injury to those regions?
That's interesting you mentioned the putamen because it actually seems to come up. I didn't talk about it specifically today because
Yeah,
um, again, the review we did was extensive, but it was pretty challenging to include every part of the brain in one
of
review.
course,
So,
of course.
but it has come up quite often in our research that those deeper brain structures like the putamen, the thalamus, the cingulum, they're affected partially because they're centrally in the brain. And so
Hmm.
with that impact, the brain's almost like pivoting around them and
Hmm.
can lead to damage. But I can't speak to the participants we've had t ex talking about self-awareness changes or self-perception changes, but there's definitely been injuries to or changes to the putamen and definitely people reporting changes in their comfort so with social functioning and emotional functioning. So I mean it's probably there and we're just not probing it the right way with the symptom questionnaires.
Yeah, that's the thing that why, I've been interviewing brain injury people just it's almost like a revenge or trying to get. So in my experience, I had the right side of my head was crushed, mainly right parietal, but it extends pretty far on both ends. And I remember once I realized this feeling that I called my mind was not my mind. It basically was my internal self was gone, and I couldn't make sense of that until way later when I started learning about neuroscience and those brain regions. And I've had that kind of discussion or different versions of that discussions with other people. And then I want to trace it down to a brain region, but really likely it's that whole shift. And it is a true inner change of self or loss of self that is it's almost ineffable. But yeah, so that's cool that you're getting into that. Maz, you had a question?
Yeah, I'm part of a study. My brain's going to be donated after death. So they did a bunch of tests throughout the day, and then they chose to put the fMRI at the end of the day. And we were to stay alert, but it was like a passive where they just showed pictures just to help us stay alert. And at the end, the guy asked me if I fell asleep. We weren't allowed to fall asleep, and I was fighting hard because it was at the end of the day. He asked me if I fell asleep, and I felt, accused, and I knew I was fighting hard, and I knew I didn't fall asleep. So I was just wondering if the fMRI can detect it or if he was just observing what happens with me when I fatigue is that I actually get partial paralysis where one side of my body is is not really working. And so I determined that that's actually sleep paralysis happening. It's like half of my brain. And I took circadian rhythm classes, and they said that this doesn't happen, but it's like half of my brain goes to sleep to try to restore itself, and then it'll switch to the other side. So then the other side gets partial
Hmm.
paralysis. So I can like use only half of my body at one time when it's at that fatigue state. So I was having difficulty getting off the table because I was having a little bit of that. So I was just curious,
Yeah.
did he notice it on the scan at the time, or was he just making observations of me after me trying to get off the table?
That's a really good question. I know a lot of scanners have like a like a motion detection feature. So I know when I've fallen asleep in the MRI before, kind of jolt awake, and uh, the technologist was like, "Hey, you fell asleep. I saw you like wake up and move a bunch." So it could have been that. Sometimes they'll measure your breathing as well, just different studies or different aspects will measure your breathing. So they might be able to see that your breathing um, fell more into like a sleeping pattern type of breathing. Um, if they're doing an fMRI, like maybe I'm not sure if they could have analyzed it right away or got some kind of preliminary information, but if you were sleeping, there might be certain parts of the brain deactivated because if you're sleeping, you don't need to be doing certain things, but other parts might be more active if you're, dreaming or something like that. So
That's what
that's
I was
kind of
curious.
fun.
Yeah,
Yeah.
that's what I was curious because I knew I was alert. I was awake the whole time. I knew that
Yeah.
I did not lapse off because I was fighting. I was
Yeah.
fighting hard. And
Yeah.
so I was interested in that, wondering because that could help me understand this partial paralysis and all these other, some of the experiences I'm constantly trying to get at, what is actually happening at the most fundamental level
Yeah.
that underlies these symptoms and possibly help other people with brain injury. Because I know I'm helped by some things that I do.
Can I
Yeah.
interject? Because the
Yeah.
fatigue with brain injury is a really big problem. And I don't think they understand the metabolic, let alone what is happening in there. But that would be something important to document and to study. And I
Yeah.
didn't have a fatigue like that. I had a mental fatigue. And I've talked to many people, and it's people describe it as bodily, or people describe it in very different ways. So if you had that, that's different, a little bit different from sleep and very specific to brain injury. Definitely worth studying though, because that's a big problem that comes with brain injury that I think is not recognized.
You can dive into
It
the,
happens.
oh, sorry, go ahead.
Well, I was just going to interject for a quick second. It happens to me too because when I neuro fatigue to the point where my brain, it literally is like a car running out of gas. It just shuts down. Doesn't matter what I'm doing. My brain starts to go to sleep. It first affects my words and my speaking, and then it affects my physical body, and I cannot move. It's like, but I'm not actually asleep. I don't know if it's a different kind of state. I don't know if that I heard, but I haven't researched it. When you go to sleep, there's something to keep your body from moving so you don't hurt yourself while you're sleeping. So I don't know if that's like a hormone or chemical kicking in, because I really don't know that much about it. I haven't researched that part yet. But when my brain fatigues, I used to call it shutdown or physical collapses, because it used to happen every day until I did 2 inpatient brain TBI rehabs. And the thing they taught me that was the most important, my biggest takeaway, was pacing. So it doesn't happen every day now. It happens every 4 months. But I also don't do hardly anything, literally. I'm pretty much couch bound. So I've been trying to get to the bottom of, okay, the neurofatigue is actually shutting me down physically, but where I can't speak and I can't move. And then if I rest for 30 minutes to 2 hours, I can kind of come back and start, speak again. But, and I haven't been able to figure out, I've only met Maz and a couple other people that have that same symptom where the body just shuts down on the spot.
And I
don't
have
know
to
what my
say
point
that
is. I just wanted to say
I
that you're not alone, because that's what my experience is, and it seems to be like a rarer form of a symptom for brain injury. So that's
I
just my
think
two
it's a
cents.
huge, I think every brain injured person that I've met has this, and I had it for years. And the way I learned was to not let my body get to that stage. But I had a mental
Right.
knockout, like
Pacing.
a physical knockout of my mind. It was so hard to describe. But I'm gonna do a talk about that November 10th, and Dr. Jared Brown is
The
gonna
difference
come.
being, the
Anyway,
difference being is
but
I'm
it's a
actually
very
still
important.
awake. I just can't talk or move
Right. It's an
when it
unlike
happens.
any other issue, I believe. Ethan, maybe you can study that in the future, the fatigue state, because when it
Yeah.
hits with brain injury, it's
Yeah.
like it's very debilitating and not understood.
Yeah.
Right.
Yeah. I'm I've really focused on mild TBIs or concussions rather than more serious things that
Mine was a mild TBI. Mine was
okay.
a life-altering mild TBI. So I was
Yeah.
going to mention it earlier, and then I decided not to. But they're working on recategorizing the naming of them, because you can have a severe injury and still kind of recoup, and then you can have a mild injury that is completely life-changing, and that's what happened to me. So
Yeah. Well, I'm sorry to hear that. It's
I think
um
there's misdiagnosis out there where
that could be
they
too.
determine
Yeah.
it mild when it's not. Um, Mine was moderate to severe, but other people just like, oh, you don't have a brain injury at all, where that's not true. So
mhm.
Another issue is that even a less severe injury, if it's not treated, can lead to worse problems because of the nature of what got injured in the brain needs to be repaired. And if it doesn't, it has an aggravation and it has a sort of downward spiraling of things. And many of the people that I meet, Moz and Holly included, are people that don't really have outside help. And it's a very horrible situation, which is, I think, why this research is so important.
thank you.
Um, yeah, no, thanks so much for everybody for attending, and Dan, thanks for including me and reaching out in the first place. It was really great conversation today. Really happy I could share my work with you guys, and hopefully at least you could take something away from today, even if it was maybe a little too technical. But there's so much more work that needs to be done, and the more people that can focus on the personalization and taking really a look at each individual person, their lifestyle, their own symptoms, and medical history, and just trying to look at more of a comprehensive picture. Hopefully, that leads to a whole lot more people getting the treatment and the help they need. So hopefully, our research can provide, a little contribution to that.
The interesting thing I've met is for each brain injured person, they have very specific problems that they can talk about. I call it the core problems because for me, it was like these are the problems at the core. Everything else revolves around them. And I keep seeing that overall relationship with each person and their internal problems. And they're always different. So there's a heterogeneity, but it's like that's what that person needs help with. And that seems to be true for almost every brain injured person. So, yeah, we need a lot of help. So, all right. Thanks, man.
Thank you.